Thank you for that nice introduction. So I am involved in a project with JBI. We have a team of 9 staff from different clinical units throughout NALHN. The units that our project team have come from are quite varied. So we have paediatrics, we have women's health, we have a safety and quality consultant, ICU, surgical wards, aged care, rehab, PAL care, medical wards, older persons mental health, and forensic mental health as well. So the reason staff were chosen from those areas to participate in this project is because of the diversity of the patients cohort that come through those areas and the different workflows. So we're hoping just to get a really widespread of different areas, because the ultimate goal of our project is to actually implement the strategies that were successful as part of our project across NALHN. So we want them to be applicable to lots of different areas. This is our team when we were undertaking our training project with our implementation training with JBI and some of our JBI team that are supporting us along the way. So we are utilising the JBI best practice guideline for safe medication, so we're very fortunate that that document already exists. We don't have to undertake analysis of research to come about that information. We're also using one of the papers that Lucy showed earlier, which was the same project that was undertaken at St Vincent's Hospital in Sydney back in 2024, so that's been quite useful as well. And we're using the JBI's 7-stage approach to evidence implementation, which is about using audit and feedback and following the structured framework, and using GRIP, which is getting research into practice, which is a process to help identify barriers and enablers and implementation strategies. And like Joe, we also gained HREC approval, which will give our project good governance. There are several important ingredients that we feel are needed for our project to be successful. Primarily is probably the importance and the relevance of our topic. So medication safety is something that has always been talked about. How can we make improvements and how can we make changes? So at NALHN, our values are really at the heart of our organisation, and they do inform our culture and the way that we work. We do take our values very seriously, and that influences the way that we view medication errors and incidents. We want our customers to have confidence in NALHN and know that we're striving for safer, more reliable medication practices, and that we're doing something proactively to improve safety. So as part of that, we strive to understand the impact that errors and incidents have on our consumers, and also the staff that are involved in administering medications. So nobody likes to make a mistake, and we often punish ourselves more than anyone else can if we do make a mistake. And there's a flow-on effect to the people that we're working with, being in a unit that is perhaps known for having lots of mistakes, and the managers that have to investigate those errors or incidents right through to our clinical governance. And that's really why engagement with our consumers and our staff at all levels is very important to the success of our project. So the stakeholders in our organisation, so clinical governance is very important. So our project goal came directly from our high-level organisation leadership. So we are continually presenting our plans and updates, and having the support for our plan means that we can have access to the time and the resource that we need to follow through with the project. And we know that a lot of areas have implemented strategies for improvement in the past, but with varying degrees of success. And we feel that we need a more definitive answer to the issues of compliance, and we need improvements to be transferable and also sustainable. So having the support of executives is really, really important, because it enables us to have the commitment from each division and the clinical areas to support and to participate. JBI team are also very, very important to us. They're providing our team not only with the training but the guidance and the supervision of the project, working with us. We meet every fortnight, so we have quite a structured approach to our project, and they also help us with accessing the tools and the practical support that we need along the way. Our project leads, so our team of 9 people are all experienced staff who have leadership positions in their clinical areas. They all have diverse range of skills such as expertise in education and leadership, IT skills, safety and quality, and having those different skills are an essential part to the components to our team being successful. The other thing about our teams is that everyone is known and respected in their clinical areas. They have the drive and the passion and the skills to make the project successful. And we have the human connection with the people that are going to be making the changes as well. So we're not outsiders that are coming in and dictating changes or telling people simply what they need to do or what they need to change, but we know our teams and our teams know us. And then our clinical leads, so having buy-in from the staff who are going to be making the changes, the people that are undertaking the administration and the support from their immediate teams that provide them with the resources to be able to do this. So engagement with consumers, we have undertaken consumer and community engagement forums because we want to know what the perspective of the consumer is. We're listening to their stories and gaining understanding on their perspective on what they see as being contributing factors to errors and incidents, because it can be quite different to what we think. And some of the consumers, if they've been involved in an error or an incident, what impact it actually had on them, and being able to share their stories with staff makes the project more relevant as well. Staff being able to share the information about what's happening in their units, the number and the nature of incidents that's been occurring within their own units, rather than just being NALHN-wide data, what is actually happening in their backyards. Being able to give them information about the steps within the best practice guideline that are being missed within their units, and also being able to compare their results with other units on a whole, and being able to share that information that we've gained from our consumer engagement, and enabling staff to have a voice and to be able to contribute to the solutions rather than us coming and introducing blanket educational blanket changes that might not seem relevant or achievable to that group. And the individual units have identified staff that are going to be that will be champions within their units and help us with some of the tasks that we're undertaking, like the auditing and being champions for the implementation and sustaining of those changes. Systems that we're engaging with, so we have existing data from systems like our SLS reporting system. It tells us how many incidents we're having and of what nature they are. We also are using existing auditing that's already been undertaken by our safety and quality teams around medication administration, and JBI software, which is giving us the project management tool, and will help us with the auditing and interpreting of results as well. And then our governance team. So we have endorsement and full support and a very enthusiastic governance in our organisation. That means that we're presenting our plan and providing regular updates to governance meetings at all levels through our standard 4 committees, our Drugs and Therapeutics Committee. We also have a multidisciplinary support for our team, so we have medical officer and pharmacists, because although they're not directly involved with our project, because it's a nursing and midwifery-led project, they certainly have a lot of skills and knowledge that they can share with us and that we can tap into. So far we have undertaken some information collecting. So we've undertaken staff surveys, which were we had 135 people that completed our surveys, which was quite a good engagement, and that was about assessing the knowledge, attitudes and behaviours of staff, which was really about assessing the readiness and the appetite for change within those units. We've also undertaken observational audits, so we've taken the best practice guideline, and which has 23 steps to it, which sounds like a lot, and we've actually assessed what practice looks like compared to those steps, and then from that we'll be able to identify which steps are the ones that are being missed. Because we know that we have, those guidelines that are existing, but how are people actually following them? And then, so GRIP it'll allow our interventions to be specific rather than generalised, which I think is another key. So GRIP is about the engagement and consultation with the stakeholders, reflecting on the results of those, the information that we're gathering, and together with the staff we'll be able to identify barriers and enablers to making changes and work out what is actually actionable or not, and then we'll plan some strategies to target those barriers and enablers. And from there we'll be creating possible potential solutions and an action plan. So this is some of our team involved in the auditing process. So some of the auditors were members of our project team, and some others were from the clinical units themselves. So as you probably gathered, our project is still underway. We have just finished our information gathering stage, and so our next step is analysing those results and working out what are the actionable steps and discussing those results back with the teams, and working out what we can actually do. And yeah, it's very important that staff know what's happening in their own space and helping us to work out what changes we're going to make. And then, of course, after we've implemented those changes, we will be repeating the surveys and the audits, and hopefully we'll be able to, and we'll reflect back on our SLS data as well. So hopefully we'll see an improvement, rates of medication errors and incidents. So we know that it's never going to be perfect, but because we are humans, but hopefully we can identify from our re-auditing which of those strategies were successful, and be able to have the wide, because we've undertaken our project in such a wide range of clinical areas, we'll be able to transfer some of those strategies across NALHN and make some strategies to sustain those improvements. Thank you.